So, good morning, everyone, and thanks for the invitation. And it is the innovations in cardiac pacing. So, 10 minutes is too less a time to deal with innovations in cardiac pacing, which has taken over since last 2-3 decades. But let me give you a synopsis. So, let me begin with a case. He was himself a doctor, in fact, an orthopedic surgeon. He was 65 years old, and he had an MI in 2001, LAD and RC was stented at that time. The ejection fraction was around 28-30%, and he presented to us with giddiness and shortness of breath, and his ECG showed intermittent ventricular tachycardia. And we did the check angio. We got an ISR in LAD. We fixed that with IVUS guided LAD to stent to LAD. But even after ischemic substrate was removed, whatever possible it was infected territory, so there was a scar always there. So active ischemia was removed by LAD stent. But even then, the patient was having VT, and this was in heart rate of 130, 140 heart rate. Device was not shocking, and this was a RBB morphology ventricular tachycardia. This patient had a dual chamber ICD implanted in 2014, and unfortunately, the atrial lead was displaced in 2016. And since then, the patient was having a single chamber ventricular pacing. So our first idea was, once the ischemic substrate was removed as far as possible, we had to give him AV synchrony and VV synchrony, and then we have to see how VT is, faring. And it was intermittent, coming at 1 week, 2 week duration, and we removed the atrial lead, implanted the new atrial lead, and then a coronary sinus lead. And this was a Gallant device, CRTD. And final ECG morphology was this, RBB. We paced the patient at 90 heart rate to have a less ventricular tachycardia, less substrate, and less excitability. But even then, the patient was having VT. Even after the procedure in the CCU, the patient had a VT, and we had to convert it with NIPS, non-invasive programmed stimulation through device. The patient was put on mexiletine in addition to amidron and beta blocker, and he was discharged on 5th day. And the patient went home, but we kept the Gallant through Bluetooth synchrony and remote monitoring. We kept on getting emails that patient is having RV sensing, high rate RV sensing, VT episodes. Patient was asymptomatic. Most of the episodes were happening in the night, and there was no shock. And it were all self-reverting, or ATP was reverting the ventricular tachycardia. Most of them were NSVT, 15 seconds, 20 seconds, 3 seconds, 4 seconds. But a day came when we saw VT episodes up to 20. And there was even a VT episode detected, 61 VT episodes over a period of 7 days. And then we thought, let's ask the patient to come, we'll go for a VT ablation. And that moment, we called up the patient, but the patient was refusing. He was okay, he had no shock, no problem. He was doing well, he had a AV-VV synchrony. So he was having a little increase in his ejection fraction, he was feeling a lot better. But these VT episodes were going on. Patient was in Behrampur, I am in Calcutta. So what we did, we increased the dose of mexiletine from 200 TDS to 300 thrice daily. And then patient was on beta blocker and amidron. And then with this increased dose of mexiletine, beta blocker, amidron, you can appreciate from February 26th, and this is March 27th, there is no VT episodes. I have not got any mails from Merlin. So this is where we have come. Patient doing well, EF marginal better, patient is symptomatically much better. From sitting at your clinic, you can see the patient status. Patient was having recurrent VT, NSVT, and then you can decide the strategy, whether you go for an increase in the medication. We increased the medication, sitting right in the Calcutta. Patient was in Behrampur. Of course, he was a doctor, it was easier for us, but even then, remote monitoring worked, magically in this patient. So we have a lot of remote clinics, and probably the crunch of a lot of device patients are there. The clinic space is less. So this is going to be solved, and there's a typical remote clinic is going to work in future, and how it looks like in future is something like this. We have moved from days of telemetry to days of Bluetooth sync devices, where you can get feedbacks, mails, patients update, even sitting at your chamber and clinic. With irrefutable evidence, we have, with remote monitoring, you can bring down the mortality, we can increase the survival rate significantly, around 25 to 30%. And we have not 1, 2 trials, a series of trials showing this. And days are not far when we are going to program the devices sitting in your chamber. The patient is in Kuch Vihar, the patient is in, Varanasi. You are going to change the programming devices, right, sitting in Calcutta, Delhi, or Bombay, or Lucknow. Now, there is a word about so many, remote monitoring, everything, and things can be hacked. A lot of, suspicion can arise in everyone's mind. And this is something like cardiac device cybersecurity. So imagine a patient, a person like Elon Musk. He has billions of dollars, and something goes wrong in his accounts. What is going to happen? So similar kind of securities and check and balances are being utilized in pacemaker technology and CID transmissions. So it's very, very safe. That's what I can tell. And the future looks like your data can, from Apple Watch, your data from your mobiles, your data from your blood pressure measurements, your data from telephones can be collated, and and obviously from CID devices, and it can feed you, and you will know the patient status sitting in a chamber. Now coming out of these remote devices, there's a lot of buzz about conduction system pacing. What is this all about? So we have been pacing the chamber, right ventricle chamber, for last maybe since 1958, and these are the new, basically the targets. The red one is the His bundle, and the lower orange ones are left bundle area pacing. And the problem of normal chamber pacing is AF, LV dysfunction, heart failure, and this is what is a incidence. There is 1% increase in the risk of AF for each 1% decrease in cumulative right bundle pacing. So it's not a minuscule amount of risk, it's a large risk. And you go for a normal conduction pacing, you take the patient out of this all complications, and this is how we do. This is basically 315 sheath, non-deflectable. And this is 3830 lead. This is a lumenless lead. And we do RAO, we do LAO to position it. The left bundle area is positioned right in below the His, and if we draw an imaginary line from His to RV apex, this is something like 2 to 3 centimeters below that. And you go in, and then we look at the signals. You see, in V1, you get a notch at the nadir of the QRS pattern. And AVR, AVL should be discordant, at least in the initial phase, and lead 2 should be upright more than 3. So what does it indicate? Why we go for these markers before we go inside? So it indicates that we are in parahison area in the basal septum. So we go in, we see the transition of this basically a notch going up, and we get a RVV pattern or a QR pattern. And this is how we go in. You have to have a rapid screw. Gentle 1 or 2 screw is not going to work. You have to penetrate inside the septum with your entire lead. 18, 20 screws. And I will take you through some of the very, very interesting cases which we had no answer, with the conventional pacing and CRT devices. So this was an elderly female, RBB, persistent atrial fibrillation, ejection fraction of 30%, normal coronaries, and this was the ECG. You see the QRS is very wide, and right bundle branch morphology. CRT is not going to work here. What will you do? This is normal coronaries, and the LS size of this patient was 4.9 centimeters. So chances of AF recurrence is very, very high. So there is only one option. Here you go for maybe a node ablation and a CRT, or a node ablation or a LOT. So this was the LV, dilated LV, LA of 4.9. And these were all initial cases. We had a backup RV pacing, and we did a LOT CRT. You see left bundle area pacing, a lead there, and middle cardiac, through middle cardiac vein, we took it up in the lateral territory. And this was the ECG which we got. Something like you have to pace the ventricle at 90 heart rate if you do a AV node ablation, junction ablation. This is a rule. And you see the QRS, which has changed. Patient became better in next 3 months, and she is still doing well with no hospitalization after that. This was a 42-year-old gentleman with DCM, and you can appreciate the QRS, which is something like 182 millisecond. And ejection fraction was 28%. and QRS is 180. So I wanted to give him the best. So 42 years male, he has a entire lifetime for remaining. And if we fuse the complexes, if we narrow the QRS, he's going to do better. And that's why I thought I'm not going to do a CRT. I'm going to do a lot CRT in this patient. And this was the left bundle position. And then there's a coronary sinus lead, 3 leads, and this was the ECG. So if we don't say a person, or if we don't tell anybody, showing this ECG that the patient has a pacemaker, no one will come to know that patient has an ECG, a pacemaker, or a CRT. Such a fusion complex with a normal-looking ECG you get, with a optimized CRT, and no wonder the patient ejection fraction improved to 55% in next 6 weeks' time. It was something like miracle happened to this patient. Another patient, I will quickly go through cases. 56-year-old male, NYHA class 3-4, LBB, persistent AF, 28% normal coronaries. You can appreciate again here. Option is CRT, junction ablation. AF ablation doesn't work here. The LA is quite large. You can appreciate here in these echo findings. And what we did again was a lot CRT, and this was the ECG. So this kind of narrow ECGs you can get in optimized CRT. You will not get a perfect ECGs even with best of the CRTs. There is a cell-to-cell conduction, and there is a epicardium to endocardial conduction. So you be sure if you are getting a patient with a 182, 190 millisecond QRS, and you're seeing that a CRT is going to work, go for a optimized CRT in these cases. You get ECGs which will be gratifying to you, and the patient's outcome is rest assured, what I can tell at this moment. This was the echo of the patient before the procedure. This was the echo of the patient after 7 days. So there is even in 7 days, there is a difference. Finally, coming to innovations, in CSP, you can appreciate this. There is an electrode at the tip of the catheter. This is HISPRO catheter. So this was a 315 is a non-deflectable catheter. There is a deflectable Medtronic 304 catheter is there. It has just been launched in India. And this is a HISPRO, Agilis HISPRO catheter, which you can maneuver, which you can deflect as per your will, as per your position. So we have, you see this, but the problem with this HISPRO, time is up. So,
I'm sorry for the interruption.
Just last 2-3 seconds. So this was the last, so there is a CSP coming very in strong way. And then we last case, DVR patient, good LV, CHB. And this patient was very afraid of any hematoma, stopping his warfarin, going for a Eclixane, and then surgery. There's a chance of infection hematoma. So we gave the patient AV, micra AV, and you see the ECG. We talk a lot about a single chambered pacing happens in the leadless pacemakers, this and that, but you look at the micra, you see the basically the VE is the ventricle end, this is the A3 window ends here, and then there is a atrial mechanical, that is A4 we sense, and there is a VS, how beautiful it's sensing the VS, and when needed, pacing, it is pacing. So there is a VDD pacing going on, so only 2-3 corollaries are there. You don't do a VDD pacemaker, AV micra, when there is a restrictive filling. E is far more, greater than A, because you have to sense the atrial mechanical, A wave, P wave.
Dr. Dilip,
yeah,
slides are not here, so we are not, most of the persons are not able to get it. So please conclude now.
It is done, sir. So we have basically devices, remote monitoring, we have a leadless pacemakers, we have a CSP, a lot of things are happening in the pacing technology, and probably you never know where the future goes, and things are unfathomable what is happening. Thank you so much. Thanks for the patient hearing.
Thank you, Mr. Chairman. We've totally run out of time for this presentation.
Yeah, a short query. Which sheet do you use?
We use invariably 99% 315 sheet, non-deflectable.
Non-deflectable. So now, is it any your personal choice, or now the deflectable are also available?
No, deflectable, since with the experience of Agilis HISPRO, which is difficult to maneuver, and you don't get a position which you want. So deflectable doesn't work. Even US operators, I had a discussion with Dr. Vijay Raman, he still feels that the non-deflectable is better. Although he only launched 2 weeks back, I was in panel, when it was launched from Madras Medical Mission, the 304 deflectable sheath, and that procedure took 3 hours. And normal with non-deflectable takes half an hour to 40 minutes.
Maybe you're more experienced with the non-deflectable.
Yeah, but I feel what we, this is my, idea. Yeah.
Right.
We'll have to
query
move
from
ahead
the
to the
floor?
next presentation. Thank you.
Thank you.
All right, thank you.
Good morning,